Mitral regurgitation occurs when the mitral valve does not close properly, causing a backward flow of blood to the left atrium. The problem can be in the valve itself or in the myocardium. In this video, we will go through the epidemiology, causes, symptoms, clinical findings, imaging, staging, and treatment. Epidemiology. It's more common in old people. It's actually the most common valvular abnormality worldwide, affecting over 2% of the population. It's divided into two types. There's the primary type, which has organic causes affecting the mitral valve itself. The second type is the functional type, where the regurgitation is secondary to ventricular dysfunction. What are the causes for primary mitral regurgitation? There's myxomatous degeneration, also called Barlow's disease, caused by remodeling of collagen type 4. Here, the endothelial cells transform into fibroblasts and later myofibroblasts that increase the extracellular matrix thickness. You can also see annular dilatation and thickened and elongated chordae. A similar condition is fibroelastic deficiency caused by a deficiency in collagen, elastin, and proteoglycans. It's relatively common associated with chordal rupture causing prolapse. It's mainly seen in patients above the age of 60. Mitral annulus calcification is a quite common condition in the elderly that can cause mitral stenosis and regurgitation. It can be severe in patients with chronic kidney disease or hypercalcemia. Other risk factors are age, atherosclerosis, diabetes, and hyperlipidemia. Endocarditis can cause valve perforation or prolapse, causing mitral regurgitation. Rheumatic valve disease presents after a streptococcal infection, for example, tonsillitis. It's more common in women in low and middle income countries. Systemic lupus erythematosus can cause Liebman-Sachs endocarditis, which usually causes a mild and asymptomatic mitral regurgitation. Marfan's syndrome commonly causes dilatation of the aortic root, causing aortic regurgitation, but commonly also mitral prolapse. Secondary causes to mitral regurgitation. In dilated cardiomyopathy, you have dilation of the annulus and increased interpapillary muscle distance. Papillary muscle displacement can prevent the valve from closing. In hypertrophic cardiomyopathy, you can see outflow tract obstruction caused by drag forces attracting the anterior mitral leaflet, obstructing the flow from the ventricle to the aorta. An anteriorly directed jet is seen. After a myocardial infarction, you can sometimes see ischemic cardiomyopathy caused by remodeling of the ventricle. When the heart muscle cells die, it causes inflammation, and the inflammation causes remodeling. Factors that contribute to the remodeling is sympathetic nervous system activation and angiotensin II. The remodeling can also be increased from wall stress, from increased afterload or increased preload. The ventricular remodeling can cause papillary muscle displacement, preventing the valve from closing. In mitral regurgitation, the symptoms usually first present when you have developed heart failure or pulmonary hypertension. Common symptoms are dyspnea, initially on exertion, orthopnea, and decreased exercise tolerance. You can have palpitations from secondary atrial fibrillation caused by a dilated atrium. Acute mitral regurgitation can be caused by chordal rupture and prolapse. It can cause symptoms of tachycardia and pulmonary congestion. What are the clinical findings for mitral regurgitation? On heart auscultation, you can hear a pansystolic murmur. The murmur increases in the left lateral position. If there is mitral prolapse, you can hear a mid-systolic click. The murmur can radiate to the left side of the thorax. A posterior leaflet prolapse can cause the murmur to radiate towards the sternum. In anterior leaflet prolapse, the murmur can radiate towards the back or cranium from propagation via the vertebral column. Ventricular distension can cause an S3 heart sound from chest wall blood flow impact. On palpation, you can feel a strong apex beat and a brisk carotid upstroke. For labs, NT-proBNP or BNP should be taken, especially in severe mitral regurgitation. It's associated with poorer prognosis. To make the diagnosis, the primary imaging you should do is a transthoracic echocardiography. However, it's usually insufficient for grading. For grading, you instead use the transesophageal echocardiography. If the echocardiography findings are unclear, you can use a cardiac MRI to make the diagnosis. There are specific criteria for primary mitral regurgitation. The criteria for stage C, which is severe and symptomatic, are severe prolapse with loss of coaptation or flail leaflets. The regurgitant jet can be used as a criteria. It can either be central or eccentric, directed to the wall of the atrium. The proportion of the central jet to the left atrium can be calculated, and if it's over 40%, this is considered stage C severe. Another criteria is a regurgitation volume of over 60 milliliters, a vena contracta over 0.7 centimeters. This is the width of the regurgitant jet, measured in between the mitral valve leaflets. A width over 0.3 centimeters is considered a moderate regurgitation. The regurgitation fraction can be used as a criteria. If it's over 50% of the blood that the ventricle pumped out, then it's considered a severe regurgitation. Indications for an intervention in primary mitral regurgitation. It should always be treated with an intervention if it's symptomatic. If you have a dilated ventricle with an end-systolic diameter of over 40 millimeters, it should be treated with an intervention if you have an ejection fraction less than 60%. Physical performance less than 80% of the expected is an indication for an intervention. Pulmonary hypertension can be an indication if the pulmonary artery pressure is over 50 or over 60 with exercise. The indications for an intervention for secondary mitral regurgitation is not the same as for primary causes. It's indicated for chronic severe mitral regurgitation if you're going through coronary artery bypass surgery for other reasons. What interventions can you do? You can do a mitral valve repair where you can patch holes, reconnect valve flaps, separate fused leaflets, or repair chordae. An annuloplasty, which is reinforcement of the annulus, can be used for secondary mitral regurgitation. A mitral clip can be used for patients that aren't suitable for surgery. Here, the cusp ends are fused in the middle with a metal device. Medications. They are primarily used to reduce afterload, decreasing the resistance to the aorta, making less blood flow back to the atrium. ACE inhibitors decrease afterload, and they also decrease ventricular remodeling. Diuretics can be used for pulmonary congestion, mainly furosemide, but also spironolactone. Thank you for watching. Please like and subscribe. If you want to revise what we went through in the video, you can download the app in the description. And if you want to see more videos like this, you can check out this video. Bye bye.